Welcome back to Ophthalmology for undergraduates and postgraduate beginners. Today we are going to discuss about the examination of cornea. Examination of cornea, we should consider three aspects of the cornea. One is the size of the cornea, second one is shape of the cornea, and third one is the transparency of the cornea. Size of the cornea is 11 millimeters in diameter vertically and 11.7 millimeters in diameter horizontally. If the diameter of the cornea is 13 millimeters or more, then it is called as megalocornea. If the diameter of the cornea is 10 millimeters or less, then the cornea is said to be a microcornea. Next is the shape of the cornea. Cornea, actually it is elliptical in shape because of the difference in the diameter of the vertical and horizontal. But actually it appears hemispherical because the difference between the two diameters are very minimal. The next thing we have to see is the transparency of the cornea. Transparency of the cornea, how will you see? The underlying structures, if they are very clearly seen, the cornea is said to be transparent. The underlying structures are not clearly seen in all parts, then the cornea is said to be not transparent. There are some defects in the cornea. Cornea appears to be black in color, but actually it is colorless and transparent. Then why the cornea appears black in color? Because of the underlying iris. The iris is giving its color to the cornea. When we see about the abnormalities in the size of the cornea, we talk about megalocornea and microcornea. Megalocornea, as I have already told, the diameter of the cornea is 13 millimeters or more. In which condition you see a megalocornea. Big eyes have a big cornea. Congenital glaucomas or ophthalmos, where the eyeball is very big. High myopias, pathological myopias, the cornea may be big in size. When we talk about small corneas, that is the corneas having 10 millimeters or less diameter, we have to consider about small eyes, highly hypermetropic eyes. We have to think about microphthalmos. Now, let us see about the abnormalities in the shape of the cornea. Cornea, as we have already told, it appears to be hemispherical. The cornea has a certain diameter of curvature, certain radius of curvature. But in certain cases, the cornea may be bulging in a huge curve, which is called as keratoglobus. Keratoglobus. The cornea appears to be very much curved and bigger. Sometimes the cornea may be conical in shape. Keratoconus. Keratoconus. The cornea will be conical in shape. How can you identify that? You ask the patient to look down. When you ask the patient to look down, the lower eyelid becomes conical in shape. It is called as Munson's sign. Another abnormality in the shape of the cornea is cornea plana. Cornea does not have any curvature at all. It appears to be flat. It is due to congenital abnormalities or due to ulcers of the cornea making a scar and making this cornea becomes plain. The eye will become highly hypermetropic. The first two conditions, keratoglobus and keratoconus, the eye will be myopic. But in cornea plana, the eye will become hypermetropic. Coming to the most important thing in the examination of the cornea, that is its transparency. Cornea can have opacities. Opacities of the cornea can be classified clinically as bilateral corneal opacities affecting both the eyes or unilateral corneal opacities affecting only one eye. Bilateral corneal opacities are classical of corneal dystrophies. Dystrophy is a hereditary condition which will occur in both the eyes. There are multiple types of corneal dystrophies. Each one of the dystrophies manifest at particular period of time in our life. When you consider about unilateral corneal opacities, you have to think about many conditions. Before going to that, we will consider two things in the classification of corneal opacities. One is with ciliary congestion or circumcorneal congestion, and without ciliary congestion or circumcorneal congestion. Already when we discussed about conjunctiva, we told that congestion more around the cornea is called a ciliary congestion or circumcorneal congestion. That is what we are considering here. If there is a ciliary congestion associated with a corneal opacity, then the diagnosis can be one of these things. One is a corneal ulcer. The second diagnosis is corneal edema caused by acute congestive glaucomas, or a glaucoma having a very high intraocular pressure leading to corneal edema or collection of water in the corneal layers. The third important thing we have to consider about a corneal opacity with the ciliary congestion is uveitis. What is opacity you will see in uveitis? In uveitis, there will be keratic precipitates on the back of the cornea. Keratic precipitates are nothing but deposition of blood cells, WBCs, on the back of the cornea. There are several types of keratic precipitates. Depending upon the type of keratic precipitates, you will see multiple brownish or red or mutton fat like dots on the back of the cornea. On the posterior surface of the cornea, there will be multiple in number. Next, we go to the corneal opacity with no ciliary congestion. There is no congestion at all in the eye. Eye is quiet, still the patient is having a corneal opacity. Where will you see? You see in a corneal scar. Patient has had an ulcer before. It has completely healed. It has become a scar. Then you don't see a congestion. Patient, as we have told, may have a dystrophy. Already I told it may be bilateral most of the time. Sometimes it may be unilateral because there is maybe a asymmetry in the occurrence of the dystrophy. One eye, the dystrophy may start early, other eye it may come little bit later. But in dystrophies, the congestion most often will not be there. Corneal degenerations. Degenerations means exposure to multiple atmospheric toxic substances or dust or all this UV rays will lead to changes in the cornea. That is degenerations. It is not hereditary. Most often it will occur unilaterally. Sometimes it can be seen bilaterally also. There also, most of the times you don't see any congestion around the cornea. Let us see about some of these conditions in detail. The most common corneal opacity we see is the arcus senilis. Our students are very fond of this arcus senilis, but most of the time they do not know how to describe it. Arcus senilis or juvenilis is nothing but deposition of lipids in the layers of the cornea. So, how it will appear like? The arcus senilis or juvenilis will appear like a whitish ring in the periphery of the cornea. This whitish ring will be separated from the limbus by a clear zone of cornea that is called as lucid interval. Lucid interval. The outer border of this whitish ring will be well defined. The inner border will be not that well defined. It will have an irregular thing. So, Yeah, arcus senilis or juvenilis is a opacity in the periphery of the cornea which is circular in shape, white in color, and it has a well-defined outer border and ill-defined inner border. It is separated from the limbus by a clear zone of cornea that is called as lucid interval. Next important problem we come across in the transparency of the cornea is a corneal ulcer or a corneal scar. The corneal ulcer has 4 stages: stage of infiltration, stage of active ulceration, stage of regression, and stage of cicatrization. The first stage of infiltration, there will be a corneal opacity which may be small area of infiltration which is well defined, and the cornea is surrounded by ciliary congestion. The next is a stage of active ulceration. Here you can see a defect in the cornea. Defect in the cornea, it is a well defined defect will be there in the cornea. In the defect you can see necrotic material, dead cells and dead organisms can be there in the defective area. Surrounding this defect you can see whitish opacity, that is an area of infiltration by both organism as well as the infiltration by immune cells and also collection of edema. So it will be associated with circumcorneal congestion or ciliary congestion, that is the stage of active ulceration. The third stage is stage of regression. The ulcer has started to heal. It appears to be a big defect in the cornea. There is a big defect in the cornea, but the defect will not have any dead cells or infiltration. The surrounding cornea will be clear, the defect also will be clear, and the congestion will be reducing. The circumcorneal congestion will be reducing. So this is a corneal ulcer stages where there will be surrounding inflammation. Next we go to a corneal scar. That is the fourth stage of corneal ulcer, that is stage of cicatrization. The ulcer heals to become a scar. So it is a well defined opacity in the cornea, and the cornea will not have any congestion around it. The opacities of the cornea can be of 4 types. One is a nebular corneal opacity, second is the macular corneal opacity, third one is leucoma, fourth one is adherent leucoma. Corneal scar is a very common case that will be kept in examination for undergraduates. It is a short case. Let us see in detail about the different types of corneal scars. The first thing is the nebula. The nebula is the thinnest scar because the ulcer has affected only the Bowman's membrane. So the scar will also be very, very thin. It is barely visible to our naked eyes. It has to be seen with some difficulty. The underlying structures, when you see through that nebular corneal opacity, that is the iris and the lens, they will be visible and they are very, very clear. You can see the details of them. Next, coming to the macular type of corneal opacity, the opacity is visible to our naked eyes. It is slightly greyish white in color. It is just like a cloud. You have seen cloud in the sky. If the sun is behind the cloud, you can see a yellowish color to the clouds, but the sun will not be visible. Similar to that, in macular corneal opacity, you can see the underlying structures. You can see the iris, you can see the lens, but they are not clearly seen. The details are not clearly seen. Next is a leucoma, leucomatous corneal opacity. The very thick opacity because it involves the entire thickness of the stroma. The opacity appears whitish in color or yellowish white in color or yellowish in color. When you see the underlying structures through the opacity, they are not at all seen. You do not know what is behind it. Whether there is iris, whether there is lens, nothing is visible. The fourth type of opacity is adherent glaucoma. Adherent glaucoma is a condition which occurs in perforated corneal ulcers. Corneal ulcer, if it has perforated and the iris has closed that perforation, then both the iris and the perforated cornea, they heal together to form a scar. Within the corneal scar, the iris is incarcerated. It is involved in the scar. So, the scar or the opacity will look brownish yellow or brownish white in color, or there will be brownish pigmentations within the scar. It is classical of previous perforated ulcers. Let me just brush your knowledge about the different types of infective corneal ulcer. The first type is a bacterial corneal ulcer. In bacterial corneal ulcers, the margins of the ulcer will be well defined. The color of the floor of the ulcer will have different colors depending upon the type of organisms. The patient in all types of corneal ulcers will have pain, water, photophobia, discharge, defective vision. All those things will be present. Coming to the fungal etiology of a corneal ulcer. A corneal ulcer which is there without much pain or symptoms. You can see a big ulcer but the patient will not be complaining much. The ulcer will not have a clear-cut edges, it will have feathery edges. A big ulcer will have a small ulcers around it, that is called a satellitism. Within the floor of the ulcer, you will have a dry-looking, curdy white infiltrates. Curdy white-like infiltrates will be present. Next, coming to the viral corneal ulcers caused by herpes simplex virus and herpes zoster virus. It will have a dendritic pattern. If these dendrites they join together, it will become a geographic pattern. Initially, even before this dendritic pattern, the patient will have multiple epithelial erosions. All these things can be clearly seen using a fluorescence staining, 2% fluorescence staining. You should be able to differentiate between a herpes simplex ulcer and herpes zoster ulcer. Herpes simplex ulcers will have knobs at the end of the dendrites. Zoster will not have knobs. Next, most important thing is Hutchinson sign. In case of herpes zoster viral keratitis, there may be a bleb or small swelling at the tip of the nose, that is called as Hutchinson sign. Another important infective cause of corneal ulcer is the acanthamoeba keratitis. Here, a patient will have a radial keratoneuritis. The patient may have a very small ulcer, but the patient will be jumping in pain. So much of agony will be there to the patient. So, simple way of differentiating the different types of infective ulcers I have told. There are so many things other than this which you can refer in the books. Whenever you think about a fungal etiology for a corneal ulcer, you should ask the patient about a history of injury with vegetative matter. That is very, very important. Vegetative matter may be a thorn, it may be a rice grain, or it may be when the patient working in the agricultural field, injury with the leaf of the plants. These things may lead to fungal ulcers. In active corneal ulceration, you can see collection of whitish material in the anterior chamber, which gives a appearance of a corneal opacity on the inferior aspect. Actually, the cornea does not have any opacity in this region, but it is because of the collection of WBCs or pus cells in the anterior chamber which has settled to the bottom. The cornea appears to be white in the inferior aspect. This is called as hypopyon. Hypopyon are of two types. One is a shifting hypopyon, other is a non-shifting or immobile hypopyon. The first thing is, that is, mobile or shifting hypopyon will have a flat upper surface. When you move, when you lie down, the hypopyon will go on this side. When you be nearly erect, it will be on the inferior aspect. When you stand upside down, the hypopyon will go superiorly. So this keeps on moving. This will have a flat upper border and it is shifting. The second important type of hypopyon is caused by fungal infections, fungal corneal ulcers. It is a non-shifting type of hypopyon. It will have a dome-shaped appearance. It will not move with the movement of the eyes or the body, and it will have fungal hypal elements within that, making it immobile. Last but not the least, in this video about examination of the cornea, we will just tell about the difference between the dystrophy and the degeneration. Dystrophy is genetically acquired or hereditary. Degeneration is due to long-standing diseases of the eye like phthisis bulbi, long-standing iridocyclitis or uveitis, long-standing glaucoma. All those things can lead to degenerations. Degenerations, you know about calcific band keratopathy, Salzmann nodular degenerations are occurring. Multiple nodules in the periphery will be present. You have band-like opacity in the inferior aspect of the cornea. So that is about long-standing diseases leading to degenerations. Dystrophies will occur in both the eyes, even though it may be asymmetrical. Degenerations, most often it occurs only in one eye. Dystrophies are most commonly seen in the center of the cornea. Degenerations are usually seen in the periphery of the cornea. Dystrophies will not have any vascularization of the cornea. Degenerations will have vascularization of the cornea. This is how we differentiate between a dystrophy and degeneration. I hope I have touched many things that are commonly seen in the OPD condition in cornea. Cornea is a very huge subject which has to be learned over several days. Let us not go into such details in this short video. We will stop here. Let us see about the anterior chamber in the next video. Thank you.